Welcome to the Radong Smart Review Head and Neck Cancer series.
Today, we are really undertaking an in-depth exploration of some head and neck scenarios that they frequently test a resident's judgment, their sequencing ability, and frankly, their therapeutic restraint during oral boards.
Right.
We are focusing on HPV, negative oropharynx, unknown primary, and of course, salvage strategies.
We've deliberately structured this deep dive around what we call the curveball scenarios. I mean, you already know the standard, straightforward 2, 1, and 0 P16 positive tonsil case.
Right, that's a bread and butter.
Exactly. But when the P16 status flips, or when the primary is hiding, or, and this is the big one, when the patient recurs after a full dose of radiation, that's where true clinical mastery is revealed.
It really is. It's not about just memorizing the ideal dose.
No, it's about navigating ambiguity and managing these really high-risk patients.
That's exactly right.
Yeah.
The examiners aren't just testing your memory, they are testing your ability to build a logical framework, under pressure. Our mission today is to give you that clean, board-safe framework for these challenging situations. We have 3 core objectives we really need to nail down.
Okay, so first, we are going to articulate the profound biological difference between the high-risk tobacco-associated P16 negative oropharynx patient and the much more favorable HPV-positive population.
And we have to be clear on this.
We must. We have to clearly establish why there's absolutely no de-escalation lane for the former.
Second, we're going to construct the optimal step-by-step workup for the unknown primary.
This is a sequencing question.
It's all about sequencing. This means detailing the clean escalation that culminates in the modern high-yield transoral diagnostic step, which, when you use it correctly, can localize a hidden primary at, genuinely impressive rates.
And that allows for much smarter radiation planning.
Precisely.
And finally, number 3, we're going to outline the essential criteria for selecting a salvage strategy in patients who have already been irradiated.
This is the hardest conversation.
It's the hardest conversation in head and neck oncology, full stop. We need to know who we can aggressively treat for cure, who needs supportive management, and how to counsel them honestly about the high and sometimes, catastrophic risks involved.
Okay, so before we dive into the theoretical frameworks, let's ground this whole discussion in clinical reality. We are going to introduce 3 linked cases. We'll call them case A, B, and C that will anchor every single principle we discussed today.
Perfect. Case A sets the stage for our high-risk index patient, HPV negative oropharynx. So we have a 64-year-old man, a truly heavy smoker, a terrifying 50-pack year history.
Wow.
He presents with the classic symptoms: progressive throat pain, ear pain. It's been going on for months. Flexible scoping reveals a 2.5 centimeter ulcerative mass firmly embedded at the left tonsillar fossa, and it's extending onto the soft palate.
And the nodal disease is substantial, a palpable 3 centimeter firm left level 2 node. The imaging then confirms the locally advanced nature of this thing. MRI shows not just the mass, but clear mandibular cortical erosion.
That's a huge finding.
It is, and the PET-CT is essential. It stages the neck and confirms no distant disease. Crucially, the final pathology is moderately differentiated squamous cell carcinoma, and the P16 immunohistochemistry is unequivocally negative. That detail immediately locks us into a high-intensity path.
Okay. Case B is our classic unknown primary scenario, but with that modern, very common biomarker twist. This is a 52-year-old man who, thankfully, has only a minimal tobacco history. He presents with a painless right neck mass, 3.5 centimeters, and it's notorly cystic appearing, located in level 2.
The initial workup is good. FNA confirms squamous cell carcinoma. And here's the game changer. The biomarker is positive P16 positivity.
Right.
Now, here's the challenge. The comprehensive head and neck exam, including flexible nasopharyngeal and endoscopy, shows 0 mucosal lesion. CT neck, with contrast, also fails to identify a primary site.
But that P16 positivity tells us exactly where the primary should be, even if it's hiding.
Exactly. This is the situation that forces the entire diagnostic sequencing question we're going to tackle later.
And finally, case C, this is the tough one, our high-stakes salvage candidate. A 58-year-old woman who completed definitive chemoradiation 70 gray with concurrent cisplatin 3 years ago for a T3N2BP16 positive tonsil cancer. And she had a wonderful complete response initially.
But now, 3 years later, she has progressive dysphagia, and the imaging shows a PET-avid 2 centimeter recurrence localized precisely at the prior primary site, plus a new ipsilateral level 2 node. The biopsy confirms recurrent squamous cell carcinoma.
And this is key for her candidacy.
It's everything.
There are no distant metastases, and she is still managing a soft diet. She's not feeding tube dependent. That preserved baseline function is perhaps the single most crucial detail when you're assessing if she is a feasible salvage candidate, or if we need to pivot to supportive care.
That's the fork in the road right there.
Okay, let's start where the boards start. Case A. We need to deliver the 60-second board script that crisp, definitive management plan examiners expect when they're faced with a specific, locally advanced P16 negative case.
This script is absolutely critical. It shows you know the staging, you know the workup, and you know the intensity required. Take us through the standard management for case A.
This is a 64-year-old heavy smoker with P16 negative squamous cell carcinoma of the left tonsil with mandibular cortical invasion and a single ipsilateral level 2 node, clinically staged T4A and 1M0 using AJCC 8th edition HPV negative oropharynx staging. The required workup includes cross-sectional imaging and PET-CT for complete staging, comprehensive dental evaluation, nutrition and speech-language pathology consultation, and multidisciplinary tumor board review. Standard management is definitive concurrent chemoradiation to 70 Gray in 35 fractions with cisplatin because there is no de-escalation role in P16 negative disease. I would treat the gross primary and involved node to definitive dose with bilateral elective neck coverage, including the mandatory retropharyngeal nodes, utilizing IMRT planning techniques. I would counsel the patient about acute risks, including severe mucositis and dysphagia necessitating a feeding tube, and late risks, including chronic xerostomia, long-term swallowing dysfunction, and the elevated risk of osteoradionecrosis given the proximity and invasion into the mandible.
That is the template. It's clean, it's comprehensive, and it hits all the non-negotiables. Correct staging system identification, the full intensity therapy mandate, and that preemptive counseling about disease-specific risks like osteoradionecrosis. If you can deliver that verbalization quickly and accurately, you've passed the clinical judgment hurdle for that case.
Excellent. Now let's dig into the core content, beginning with Section A, what these diseases are. We have to start by understanding the profound biological chasm between these two major oropharyngeal cancer populations.
Absolutely. The P16 negative OPC is not just a different stage. It is a fundamentally different disease. It is biologically and clinically distinct from the favorable HPV-positive disease. Well, the negative subtype is intimately associated with that history of heavy tobacco and alcohol use. It affects older patients who, often have significant comorbidities, and it results in profoundly worse local regional control rates and overall survival outcomes compared to the HPV-positive subtype.
That biological difference really means we cannot relax. The core clinical pearl here, the one you must state explicitly on your boards, is that you treat HPV-negative disease like any other aggressive head and neck squamous cell carcinoma full-intensity therapy is required.
That's it.
There is simply no validated de-escalation path based on primary size or nodal status like we're seeing in all the HPV-positive protocols.
And the reason for this aggressive approach, it really goes back to radiobiology. This isn't just some localized viral phenomenon. This is often a consequence of what we call field cancerization. The entire mucosa of the upper aerodigestive tract has been exposed to decades of carcinogens, leading to multiple genetic hits.
So it's a whole different animal.
It is. These tumors are biologically more resistant to radiation and chemotherapy. If you try to lighten the load with a lower dose, or dose skipping, or reduced chemotherapy, you're basically just giving the tumor an advantage it will exploit, and that results in inevitable recurrence. The default expectation has to be maximum therapeutic effort.
That distinction is so crucial. It's the difference between treating a generally radiosensitive, unifocal, viral-driven cancer versus treating a biologically resistant cancer that's arising from just widespread carcinogen exposure.
Right. Now let's pivot and define squamous cell carcinoma of unknown primary, or SCCUP. Formally, this is defined as metastatic squamous carcinoma to a cervical lymph node without an identifiable mucosal primary after an appropriate thorough evaluation.
And in the modern era, the landscape of SCCUP is dominated by HPV. This is a critical context shift. If that node is P16 positive, we are highly confident the primary is hiding somewhere in the oropharynx.
Usually the palatine tonsil or the base of tongue crypt epithelium. The anatomy here is key. The oropharynx contains this abundant lymphoid tissue that can shed cancerous cells into the cervical lymph nodes long before a primary tumor is large enough to be seen macroscopically on a scope or on imaging.
We're talking tiny.
Well, we were talking about tiny, sometimes 2 or 3 millimeter primaries hiding deep within a tonsillar crypt that still somehow managed to produce a massive nodal metastasis.
Right.
This is why the oropharynx is the default occult site, especially if the patient is P16 positive and the node is in level 2 or level 3.
Exactly. So knowing that the node is P16 positive gives us a highly directed search pattern. If it's level 2-3 disease and HPV positive, the primary is assumed to be the oropharynx, and our entire workup sequence is designed to confirm that assumption.
Finally, let's introduce recurrent disease and the framework for salvage. Local regional recurrence after definitive therapy is an unfortunate reality, and boards will expect you to have a structured selection framework ready to deploy.
And the crucial decision point here, before you even consider the reirradiation technique or the dose or the chemotherapy, is selection.
Selection.
You must first answer, can meaningful, durable control be achieved in this specific patient without inflicting unacceptable morbidity? This is a moral and a clinical calculation that requires deep experience.
And we must internalize this principle. In previously irradiated patients, reirradiation is never automatic. The treatment, in fact, is the selection.
That's a great way to put it.
If you choose the wrong patient, particularly one with poor baseline function or a short interval recurrence, you are committing them to intense suffering and high morbidity feeding tubes, necrosis, pain for what is often minimal or temporary gain. Restraint is often the bravest path.
Let's transition now to the technical and diagnostic frameworks in Section B, workup and staging. We have to start by reinforcing the specific staging rules for HPV-negative OPC using the AJCC 8th edition.
Listeners, this is a board trap. It's designed to separate those who know the difference from those who just blindly apply the HPV-positive tables.
You can't do that.
You must use the traditional oropharynx staging criteria for P16-negative disease. Do not apply the favorable HPV-positive staging system, which dramatically downstages the disease, leading to inappropriate low-intensity therapy.
Okay, let's run through the T-stage reminders, because specific verbalization is required. Remember, these are based purely on size and extent, not on HPV status. So T1 is 2 centimeters or less. T2 is greater than 2 and up to 4 centimeters.
T3 signifies a primary tumor greater than 4 centimeters, or extension to the lingual surface of the epiglottis.
And T4A is locally advanced but still surgically resectable disease. It means invasion of adjacent bone or muscle, the mandible, the hard palate, the extrinsic tongue muscles, or the larynx. This T4A designation, like in our case A, is critical because it often dictates that upfront decision between primary surgery or definitive chemoradiation.
For sure. Mandibular invasion, for instance, immediately suggests a functionally devastating surgical resection.
Oh, absolutely.
And then T4B is unresectable disease, often involving the deeper structures, the skull base, pterygoid plates, lateral nasopharynx, or carotid encasement. If you state T4B, you are committing that patient to non-surgical treatment unless the tumor responds dramatically to induction therapy, which is not the standard approach.
And the end staging, that follows the standard criteria, but you must specifically include the clinical extranodal extension, or ENE designation. ENE is arguably the most important prognostic and treatment stratification factor in the 8th edition. It drives up adjuvant therapy intensity and the overall stage.
Okay, now let's pivot to the unknown primary workup. This is where we need to build that clean escalation sequence. The examiner is looking for efficiency, knowledge of modern techniques, and just solid therapeutic logic.
So step 0, let's define the goal clearly for the examiner. Your primary goal is to localize the primary to allow rational mucosal targeting and potentially reduce the volume of unnecessary high-dose mucosal irradiation.
Yes, if we can avoid radiating the entire bilateral oropharynx, we significantly reduce long-term dysphagia. It's a huge win.
It is. Okay, step 1, tissue diagnosis the right way. You must start with an FNA or a core biopsy of the neck node. Critically, do not jump to excisional biopsy up front. This is a common trap.
A very common trap. And on that specimen, you have to maximize the information you get. So you request HPV testing via PCR or P16 immunohistochemistry. If HPV is negative, or if the clinical picture suggests an atypical location or Asian ancestry, you must include EBV testing for possible nasopharyngeal biology.
And when you're asked why you avoid excisional biopsy, you need a crisp, board-safe line.
What's the line?
Say this. I avoid excisional biopsy because it can disrupt surgical planes, complicating subsequent neck dissection if needed, and most importantly, it can create apparent extranodal extension that alters subsequent adjuvant recommendations.
That's perfect. An excisional biopsy causes soft tissue changes and inflammation that can mimic E19, forcing unnecessary chemoradiation in what could be a low-risk case.
Okay, so we have the tissue and the biomarkers. Step 2 is the directed clinical evaluation. This means a complete head and neck physical exam plus flexible fiber optic endoscopy. You are checking all the mucosal surfaces, especially the base of the tongue, tonsils, and hypopharynx. If you see any suspicious lesion, you biopsy it.
Step 3 is imaging escalation. Begin with a contrast-enhanced CT neck, or MRI, which gives you excellent soft tissue and bony detail. If no primary is seen, you must proceed to PET-CT.
The PET-CT is vital.
It is because it can identify an occult primary in a meaningful minority of patients, those that are metabolically active, but too small to be appreciated on the CT. And most importantly, the PET-CT guides targeted biopsy, showing the surgeon where the highest metabolic activity is hiding.
So if the imaging and flexible scope are all negative, we move to step 4, examination under anesthesia or EUA with targeted sampling. This is where the surgeon physically checks every suspicious mucosa under magnification and palpates for any subtle masses.
A board-safe default surgical step here, particularly in P16-positive cases like our case B, is a bilateral palatine tonsillectomy.
And why bilateral?
Because small tonsillar primaries can be so easily missed on a superficial biopsy, and even with unilateral nodal disease, there is a low but definite risk of an occult contralateral primary. You excise the entire lymphoid tissue bed.
Right, those large, deep crypt primaries are notoriously difficult to find with just superficial biopsies. Tonsillectomy is a foundational step, but we now know we can do even better, especially for the base of tongue.
And that takes us to step 5, the modern high-yield step. If imaging, EUA, and tonsillectomy all fail to localize the primary, you must escalate the diagnostic evaluation to include removal of the at-risk lymphoid tissue of the base of the tongue.
This procedure is performed using transoral techniques, typically transoral robotic surgery, or TORS, or transoral laser microsurgery, TLM. We often call it a transoral lingual tonsillectomy or base of tongue mucosectomy.
This is the key update in the management of SCCUP, especially for P16-positive disease. The base of tongue mucosa contains these deep lymphoid crypts that are anatomically designed to hide small lesions.
So a blind biopsy just won't cut it.
Standard blind biopsies frequently miss the tumor entirely. A mucosectomy-based approach excises this entire lymphoid tissue, identifying small, cryptic primaries, often T1 lesions, at substantially higher rates than superficial biopsies.
I think we need to emphasize the rationale for TORS TLM a bit more deeply. Why is this technique so dramatically better than a standard biopsy?
Well, it's the difference between scraping the surface and removing the entire potential hiding place. Imagine the tonsil and the base of tongue as having these deep, complex folds, sort of like canyons. The tumor is living at the bottom of the canyon.
Okay.
A superficial biopsy, done blindly, might only hit the rim. TORS allows the surgeon to visualize the area, identify subtle mucosal changes, and remove the entire lymphoid-bearing crypt tissue en bloc. Because the primaries are often small T1 lesions, they're completely removed by this diagnostic excision, which sometimes offers therapeutic benefit as well, allowing for highly tailored small irradiation fields later.
So how should the listener articulate this critical step on the boards, especially regarding that high localization rate?
You should state it this way. If the primary remains occult after imaging, EUA and tonsillectomy, I escalate to transoral lingual tonsillectomy or base of tongue mucosectomy using TORS or TLM, because this step has a high localization yield and frequently finds small PT1 base of tongue primaries that are not visible on imaging or superficial biopsy.
And you have to back it up with the efficacy anchors. What are the numbers we need to remember?
Okay, so across published contemporary reviews, these transoral approaches are commonly reported to localize the primary in roughly 60 to 80% of appropriately selected patients after a negative standard workup. In the most favorable group, the P16-positive SCCUP, that yield approaches the high 80s range.
That's huge.
It is. A frequently cited systematic review of lingual tonsillectomy reported an overall localization rate around 80%. This yield is significant, confirming that many primaries are hiding in the base of tongue, even after a negative PET-CT.
But let's be real for a second. A reality check is necessary. The FIND trial and just general clinical experience reinforce the truth that while this step is high yield, It is not perfect.
No, it's not.
Even with optimized workup and transoral evaluation, a meaningful fraction of primaries will still remain truly occult. That's why we must have a plan B.
And plan B is step 6. If the primary is still occult, you treat based on the presumed biology. If the patient is P16 positive, EBV negative, and the nodal disease is confined to level 2 or 3, the presumptive primary is unequivocally the oropharynx. Your radiation approach must cover the gross nodal disease definitively and cover the entire at-risk oropharyngeal mucosa to a prophylactic or intermediate dose.
Let's solidify that decision-making process with an if-then risk ladder for unknown primary, focusing on those biomarkers.
Okay, so if the patient is P16 positive with a level 2 or 3 node, EBV negative, and no primary found after imaging in EUA, then you presume occult oropharynx. You must escalate to transoral lingual tonsillectomy or base of tongue mucosectomy using TORS or TLM to maximize primary localization.
If, however, the EBV testing is positive, then you immediately manage the case as nasopharyngeal carcinoma biology.
Immediately. This is regardless of whether a discrete primary is found, because the field size, the inclusion of the entire nasopharynx, and the standard chemotherapy regimen, it all changes completely.
What if you see level 4 or level 5 adenopathy, or the histology is atypical for SCC, or if the patient has heavy tobacco exposure but is P16 negative?
Then you must broaden your search. This requires appropriate systemic imaging, a chest CT, and possibly panendoscopy based on the context, because the primary might be lung, esophageal, or somewhere else entirely outside the typical HNC field.
And finally, if the primary remains occult after the full workup, including that transoral diagnostic step, what do you do?
Then you treat the gross nodal disease definitively, and you treat the at-risk mucosa and elective neck in a way that's consistent with the presumed primary site and nodal risk pattern, which means you cover the oropharynx as the source.
That leads us to a really critical nodal map call-out for the board-safe RT fields. When the primary remains occult, but the biology is just screaming oropharynx.
It is. For mucosal coverage, the focus must be the bilateral oropharyngeal mucosa. Specifically, the palatine consular regions and the base of tongue are central. We call these areas because they are the highest probability hiding spots for the occult primary.
Yeah, for nodal coverage.
For nodal coverage, you treat the involved nodal levels to a definitive dose, typically 70 gray. Elective coverage typically includes bilateral levels 2 through 4, which is the standard elective approach when you're treating the oropharynx mucosa definitively. But crucially, do not forget the retropharyngeal nodes. They are highly relevant in the oropharyngeal predominant pattern and must be included in that elective volume.
Now, on the boards, they don't just want the nodes, they want the dose logic. You need to speak conceptually about why you chose your numbers, so justify the 3 compartments.
Right. Gross nodal disease receives definitive dosing, say 70 gray. The elective neck receives standard prophylactic dosing, maybe 54 to 56 gray. And the at-risk mucosa, the oropharynx, if the primary wasn't localized, receives prophylactic to intermediate dosing, depending on institutional strategy, perhaps 60 to 63 gray.
The key point is you can justify all 3 compartments and explain why finding the primary via TORS TLM can reduce that uncertainty.
Exactly. It allows you to potentially exclude the contralateral elective mucosa, which is a major functional win for the patient.
Okay, let's move to section C, evidence-based management and re-irradiation techniques. We already established the principle for HPV-negative management, but let's just state it one more time explicitly to eliminate all ambiguity.
Yes. No de-escalation.
No de-escalation. Treat HPV-negative oropharyngeal cancer with standard intensity, definitive concurrent chemoradiation using high-dose cisplatin when organ preservation is the goal.
Alternatively, if the tumor is resectable and massive, primary surgery followed by risk-adapted adjuvant therapy is the standard path. The key is full intensity, regardless of the sequence.
For unknown primary management, remember the goal. Localize what you can. If you successfully find and resect a small oropharyngeal primary with transoral surgery, you can often significantly narrow the mucosal uncertainty and focus your radiation volumes much more rationally. You save the rest of the oropharynx from unnecessary dose.
Conversely, if you do not find the primary, you treat the nodal disease definitively, and you target the most likely mucosal at-risk region based on biomarkers and nodal distribution.
For instance, if it's a P16 positive level 2 node, you cover the oropharynx, but you have no biological justification to cover the hypopharynx or supraglottic larynx to elective doses.
Exactly. Target the known risk areas and stop there.
Now for the most complex part, The re-irradiation planning workshop, focusing on salvage with our case C. We said the single biggest decision here is patient selection, and we meant it.
We did. I recommend structuring your answer using a mnemonic or framework, something like the MIRI criteria.
Yeah.
But the ultimate board message you need to convey is this. Patients who are favorable salvage candidates have a longer interval from the first radiation, ideally 2 years or more, and good baseline function.
Meaning they're eating well, they're not dependent on a feeding tube.
Right. These patients derive the most benefit from aggressive salvage.
And we must contrast that with the poor candidates.
We do. Conversely, patients with early recurrence, say within 12 to 18 months, and pre-existing organ dysfunction, like being feeding tube dependent, they derive the least benefit and suffer the most harm from protracted re-irradiation.
So if they're already struggling to swallow and maintain weight, adding more radiation is unlikely to improve their functional status, and it carries enormous risk.
Right, making palliation the kinder choice.
That distinction, long interval and preserved function, is exactly why our case C patient is considered favorable 3 years out and still managing a soft diet.
Let's discuss the essential technical steps for planning re-irradiation. Simulation starts with robust immobilization. This means a 5-point mask with a shoulder pull. You have to consider using a bite block or oral stents for tongue and mandible separation when it's appropriate to reduce mandibular dose and mitigate xerostomia in the non-target area.
And the CT sim must be done with intravenous contrast, vertex to carina.
Yes, and fusion is mandatory. This is not optional. You must fuse your diagnostic MRI and your PET-CT to the planning CT for precise target definition. You are operating with zero tolerance for error because the prior dose has already stressed the normal tissues. Multiple imaging modalities are absolutely essential to define the GTV accurately.
Okay, so target volumes and elective omission are the next critical steps, and this is where a lot of planners can make mistakes.
It is. In the re-irradiation setting, elective nodal irradiation, or NIR, is generally avoided. We treat only the gross disease and the immediate, high-risk, anatomy-respecting CTV. The key is restraint.
For definitive re-irradiation, your volumes must be meticulously sculpted and small. So GTV is gross disease defined by fusion. CTV is a tight anatomy-respecting expansion, often utilizing natural fascial barriers to limit spread.
And PTD is a minimal margin, maybe 3 millimeters, based on your image guidance capability. The margins are significantly smaller than the 5 millimeter or larger expansions we use in the upfront setting.
And if you are using stereotactic body radiation therapy or SBRT,
the volumes are even tighter, often GTV to PTV only, with a tight margin and absolutely no elective coverage whatsoever. This really highlights the most common planning error, treating too large a volume. In re-irradiation, every cubic centimeter matters because you are accumulating dose, and the rate of late complications increases exponentially with volume.
Let's talk dose and fractionation, which varies based on intent. For definitive re-irradiation targeting cure, what are we aiming for?
We commonly aim for doses in the mid-60s to around 70 gray range using conventional fractionation. But, and this is a big caveat, you must retrieve the prior dose map and assess the cumulative tissue tolerance meticulously before you commit to 70 gray. You need to ensure the spinal cord, the brainstem, and critical structures haven't already received a near tolerance dose.
And for postoperative re-irradiation?
For postoperative re-irradiation, when it's indicated for high-risk features like positive margins or E19 following salvage surgery, the typical dose is 60 gray in 30 fractions.
And SBRT, which is reserved for carefully selected, very small volume recurrence, commonly uses a highly hypofractionated regimen.
That's right, typically 5 fractions in the mid-30s to mid-40s gray range. This hypofractionation delivers a massive biological punch very quickly, but it also carries the highest risk of severe complications if constraints are violated.
Finally, OAR constraints. You must speak in principles and safety priorities on boards. The safety priority list in re-irradiation is, well, it's non-negotiable.
Yes.
It should state, I will retrieve the prior dose data, assess the cumulative tolerance, and set extremely conservative retreatment constraints, especially for the spinal cord, brainstem, carotids, mandible, and larynx, explicitly recognizing that the complication risk is meaningfully higher than in the upfront setting.
That demonstrates clinical responsibility, and
Yeah.
you have to explicitly name the most feared complication, the elephant in the room, carotid blowout risk.
It's one thing to write it down, but Counseling a patient honestly about this severe, life-threatening complication is where the rubber meets the road.
It is, and this risk increases with a high dose per fraction, which is why SBRT requires extreme caution near major vessels, vessel involvement itself, so tumor abutting or invading the carotid, and critically wound breakdown or fistula formation post-treatment.
So you have to show the examiner you plan around this severe, life-limiting complication by avoiding high doses to the vessel wall and ensuring minimal overlap with prior fields.
Exactly. Okay, let's apply these concepts back to our 3 clinical cases for synthesis.
Let's do it. Case: the 64-year-old heavy smoker with T4A N1M0P 16 negative tonsillar cancer with mandibular erosion. What is our core recommendation and rationale?
The recommendation is definitive concurrent chemoradiation with cisplatin. The rationale is clear. This is locally advanced P16 negative disease requiring full intensity therapy, no de-escalation. Critically, that T4 status with mandibular involvement strongly suggests that primary surgery would be functionally devastating.
It would require a segmental mandibulectomy and often a free flap reconstruction.
Right, leading to significantly worse functional outcomes than organ preservation via chemoradiation. So definitive chemoradiation is the preferred path here.
And the plan concept is definitive dosing to the gross disease, with bilateral elective neck coverage and appropriate nodal compartments, including those retropharyngeal nodes. Cisplatin remains the board standard concurrent systemic therapy if the patient meets performance status and audiometric criteria.
The counseling script here must be direct, avoiding any false optimism about the intensity. You have to frame the decision. You have a high-risk tobacco-related throat cancer involving your tonsil and your jawbone. I recommend the maximum intensity treatment, which is radiation every weekday for 7 weeks, combined with cisplatin chemotherapy. This offers the best chance of cure without major surgery that would significantly impact your ability to speak and eat.
And you must be explicit about the risks. You should expect a very sore throat, difficulty swallowing, risk of weight loss, and likely a temporary feeding tube. Longer-term, dry mouth and persistent swallowing changes are possible, and because the tumor is near the jaw, we will be especially careful about jawbone complications or osteoradionecrosis, which is a known risk in your situation.
Next, Case B, unknown primary, P16 positive level 2 node. This is a sequencing and diagnostic challenge.
The recommendation is to complete the escalation workup, ensuring that modern transoral diagnostic step is performed if the standard workup is negative.
The next steps are PET-CT if it's not done yet, EUA with directed biopsies and tonsil evaluation. And if it's still negative, the mandatory escalation is to transoral lingual tonsillectomy or base of tongue mucosectomy using TORS or TLM.
And the rationale phrasing must include the mechanism. You have to say something like, because P16 is positive and the node is level 2, the most likely occult primary is the oropharynx, specifically the tonsil or base of tongue crypts. If standard EUA does not identify a primary, I must escalate to transoral lingual tonsillectomy, which frequently identifies small PT1 primaries by excising the entire lymphoid bed and can substantially reduce the uncertainty in subsequent radiation targeting.
So what if the patient absolutely refuses the TORS TLM procedure? What's our fallback plan for the radiation field? We have to be ready for that scenario.
That is a critical contingency. If the patient refuses the definitive localization step, we have to treat based on the highest probability. Since the P16 status and nodal patterns strongly suggest oropharynx, the only board-safe path is to treat as presumed occult oropharynx.
Which means?
This means definitive nodal dosing and full coverage of the bilateral oropharyngeal mucosa, including the base of tongue and palatine tonsillar regions, and the elective neck based on the risk pattern. The goal of functional preservation is compromised by the patient's refusal to undergo the localization step.
Finally, KC recurrence at 3 years after 70-gray chemoradiation. The key features are that long interval since first treatment and the preserved function.
This patient is a highly favorable salvage candidate. The primary recommendation here is salvage surgery if the disease is deemed resectable by the multidisciplinary team. Postoperative re-irradiation must be considered in selected patients based on high-risk features found at surgery, like close or positive margins and extranodal extension, or ENE. But this plan requires frank, realistic counseling about the high toxicity risk.
The counseling script is vital. You have to detail the balance of benefit versus harm. Your cancer has returned locally. The good news is, it is still localized, and critically, you have preserved function and a long disease-free interval. Surgery offers the best chance to remove all visible disease. Because you already had full-dose radiation, Any additional radiation carries high risks that we must discuss. These include severe swallowing problems, the likely need for a long-term or permanent feeding tube, wound complications, and rare but severe vascular events. And then conclude by framing the decision. If surgery shows high-risk features, we would then discuss carefully selected post-operative re-irradiation to improve local control. But this decision must be made by balancing the high benefit of potential cure against those extremely high risks of functional decline. And we have to touch on toxicity management, both acute and late, especially in the context of re-irradiation. It's not just a footnote, it's a major management priority.
Right. Acute toxicity is not just duplicated, it's amplified. You should expect earlier onset and significantly more intense mucositis and dermatitis compared to the upfront setting. The tissues have lost much of their recuperative capacity.
So close follow-up. Proactive nutrition intervention, aggressive hydration, and pain control are not optional.
Not at all. They are essential to prevent hospitalization and weight loss.
And when you're discussing late toxicity on boards, you must name the big three consequences of re-irradiation.
Okay, what are they? Number 1, chronic dysphagia and aspiration risk. This is the main functional outcome driver and can lead to silent aspiration pneumonia.
Number 2, soft tissue necrosis or fistula risk, particularly if there was surgery or wound breakdown in the field.
And 3,
And 3, carotid blowout risk. We've discussed this, but it bears repeating. This is a potentially fatal risk that increases dramatically with volume, high fraction size, and previous tissue damage.
the entire salvage process must be underpinned by an honest goals of care discussion, explicitly addressing the patient's preferences, the alternatives to aggressive therapy, including palliative SBRT or systemic therapy, and a realistic assessment of their baseline function.
You have to ensure the patient understands that cure comes with a very high price in functional quality of life.
A quick note on controversies and advances. Immunotherapy. You have to know when checkpoint inhibitors are preferred in recurrent or metastatic disease.
PD-L1 status and TMB status can stratify patients for first-line choices in the palliative setting. While it's not standard for definitive primary treatment, it is core knowledge for managing recurrence outside of the local salvage setting.
Okay, let's hit the 3 classic oral board traps one last time before we run the blitz, just to make sure we have the nuance down.
Okay. Trap 1. Using HPV-positive staging for a P16 negative patient. Wrong staging leads to inappropriate low treatment intensity. Always confirm status and use the correct AJCC system.
The golden rule for HPV negative is, if you treat it like a bad smoker's cancer, you'll stage it like one too.
That's a great way to remember it. Trap 2. Offering excisional biopsy of the neck mass as the first diagnostic step.
Wrong sequence. Start with FNA or core, get your biomarkers, move through imaging escalation EUA, and then escalate to modern transoral localization. Avoid the excisional biopsy risk.
And trap 3. Offering protracted, aggressive reirradiation to a poor selection patient. Early recurrence plus organ dysfunction like being feeding tube dependent for several months is the classic scenario where morbidity overwhelms benefit.
You have to pivot to limited intent options like SBRT, systemic therapy, or pure palliation with an honest goals of care discussion.
Exactly.
All right, time for the board review, the blitz. We will run through 3 rapid-fire questions testing the core knowledge we just covered.
Let's do it. Question 1. A 59-year-old man with a 60-pack year history has a 3-centimeter tonsillar mass and a 2-centimeter ipsilateral level 2 node. Biopsy shows squamous cell carcinoma and P16 negativity. What is the correct clinical stage using AJCC 8th edition?
Okay. Is it A, stage 1, T2N1M0, B, stage 3, T2N1M0, C, stage 4A, T2N2AM0, or D, stage 2, T2N0M0?
The best answer is B, stage 3, T2N1M0.
And the reasoning is purely based on traditional staging. A 3-centimeter primary is T2. A single 2-centimeter ipsilateral node without clinical extranodal extension is N1. So T2N1 is stage 3 in P16 negative disease. You correctly avoided the HPV favorable system.
Question 2. A 48-year-old woman has a 3.5 centimeter cystic level 2 node. FNA shows squamous cell carcinoma and P16 positivity. CT/MRI show no primary. PET-CT shows uptake only in the node. What is the next best step?
Is it A, proceed directly to bilateral neck dissection, B, excisional biopsy of the node for definitive diagnosis, CEUA with palatine tonsil evaluation and base of tongue directed sampling, escalating to transoral lingual tonsillectomy or base of tongue mucosectomy, it's still negative, or D, begin definitive chemoradiation covering bilateral neck and larynx.
The best answer is C. This is the correct escalation sequence. You maximize diagnostic yield by including the EUA, tonsil evaluation, and that crucial modern transoral localization step via TORS or TLM.
Okay, question 3. A man recurs 18 months after definitive chemoradiation and has been feeding tube dependent for 6 months. No distant metastases. The disease appears resectable. What's the best approach?
Is it A, surgical salvage plus routine postoperative re-irradiation, B, definitive re-irradiation to 66 to 70 gray with concurrent chemotherapy, the C, prefer limited intent options such as SBRT when feasible, systemic therapy, palliation, or supportive care with explicit goals of care discussion, or D, surgery alone without further therapy is always preferred.
The best answer here is C.
The reasoning. This patient fails the critical selection criteria. The early recurrence, coupled with the functional deficit of being feeding tube dependent for 6 months, means the morbidity of protracted aggressive treatment. So, A or B will almost certainly outweigh the functional benefit. You must pivot to palliation or limited intent options.
Perfect. Let's review our clinical pearls one last time, the high-yield takeaways you need walking into the oral boards.
Pearl 1, P16 negative OPC, is a distinct, higher-risk disease with its own staging system and no de-escalation lane. Treat with full-intensity standard therapy every time.
That distinction between the two OPC subtypes is the #1 test of clinical judgment in these cases.
Pearl 2, unknown primary is a sequencing question. Tissue diagnosis with biomarkers, then imaging escalation, including PET-CT, then EUA.
And Pearl 3. If the primary is still occult after EUA, you must escalate to transoral lingual tonsillectomy or base of tongue mucosectomy using TORS or TLM. This step has a high localization yield, potentially saving the patient from larger radiation fields, but remember, it is not perfect.
Pearl 4. In re-irradiation, selection is treatment. Baseline functional status and the interval since prior radiation drive the benefit to harm calculation. If the interval is short and function is poor, restraint is mandatory.
Pearl 5. Keep re-irradiation volumes tight and elective coverage minimal or entirely omitted. Large volumes are the most common avoidable error that leads to late, devastating toxicity.
And Pearl 6. Immunotherapy is core knowledge in recurrent or metastatic disease. You must know when checkpoint inhibitors are preferred and how biomarker stratification guides first-line choices in the palliative setting.
Today, we successfully navigated 3 board-favorite curveballs: P16 negative oropharynx requiring full-intensity therapy, the unknown primary workup with a clean escalation sequence including modern transoral localization, and salvage strategy selection guided by prognosis and baseline function.
Let's quickly recap the 3 main pillars we built for this deep dive.
First, P16 negative OPC requires full-intensity standard therapy. Don't fall into the de-escalation trap. The radiobiology just does not support it.
Second, unknown primary is a methodical sequencing problem that prioritizes transoral localization using TORS or TLM to maximize target definition, though you must be ready to treat the entire occult oropharynx if the workup remains negative.
And third, re-irradiation is never automatic. Patient selection is the therapy. You need tight, focused volumes, clear counseling, and honest goals of care framing that matters just as much as the dose prescription.
The clinical stakes for these 3 scenarios are extremely high. For you to excel, you need to turn these bullet points into a detailed clinical conversation that demonstrates deep understanding of both the science and the patient's functional risk.
Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.